I may request Dr. Kausar Amin, Assistant Director Schemes, Director Health Services Kashmir, to please come on stage. Dr. Kausar has also served as Chief Medical Officer, Kupara, and during her tenure as CMO, she has been instrumental in leading from the front during the COVID spike. Ma'am has also served as Block Medical Officer, Chatargam. Ma'am, we are delighted to have you with us today. Further, I would request Dr. Humaira Noor, Assistant Professor and Head of the Department, Gynae and Obs, Government Medical College, Baramulla. Please have a big round of applause for Dr. Humaira. Dr. Humaira has been awarded as Best COVID Warrior during her tenure. Ma'am, we welcome you today. Up next, I would request Dr. Abdul Rashid Para, Medical Superintendent, DRDO Hospital, Kashmir, to please come on stage. Please have a big round of applause for Dr. Para. Dr. Para is basically consultant anesthesia and critical care. He has served as Medical Superintendent, District Hospital, Pulwama. Dr. Para was among us first batch of master trainer in ALS and BLS at Sickle and Simulation Lab of the Director Health Services, Kashmir, and has been one of the pioneers of its establishment. As Medical Superintendent of 500-bedded DRDO COVID Hospital, he has been able to establish 125 ICU beds by providing standard care during second and third COVID wave. Sir, we put our warm welcome to you. I would request our fourth panelist, Dr. Pankaj Somani, Senior National Program Manager, Health System Strengthening, working with UNDP, India. Please have a big round of applause for Dr. Pankaj. Dr. Pankaj has worked with WHO on various entomological surveys like Ricketts Seal Survey and AD Survey. Dr. Pankaj is now actually involved in implementation of and COVID platform across the country. I cordially welcome you, sir. Now may I request our final panelist, Dr. Anil Gupta, National Support Team Lead under USAID, founded MRIGHT COVID-19 Vaccination Project at JSI, India. Please have a big round of applause for Dr. Anil. Dr. Anil has closely worked with Ministry of Health and Family Welfare, Government of India, providing technical assistance to 18 states to identify challenge and facilitate the ramp-up of COVID-19 vaccination. He has also been part of WHO and PSP India for polio eradication and routine immunization. We are delighted to have you with us today, sir. Further, I would request the moderator of the session, Dr. Isha Chalotra, State Project Officer, UNDP. Please have a big round of applause for Dr. Isha. Dr. Isha has previously worked with various prestigious organizations like NHSRC, IP Global and JSI. To come on, guys, please. Ladies and gentlemen, please have a big round of applause for all the panelists seated. Before we step ahead and begin the session, let me remind our audience that we have an award for the best tweet and question on the Twitter handler #MCH Conclave to highlight your tweet. Now, I request our moderator to please proceed the session. Over to you, Dr. Isha. Thank you.
Thank you so much, Dr. Far. I would also like to welcome our esteemed panelists for this session for deliberating on long COVID-19 maternal and pediatric perspective. Pandemics, as we learning from COVID-19 outbreak, can infect and sicken societal institutions and systems just as effectively as the virus weakens its organic host. The COVID-19 pandemic is not the first, and certainly not the last to savagely hit the world. But it has accelerated lots of changes that were kind of percolating, and it has disturbed the quantum of care for sure, and it compelled the healthcare system to prioritize the health services and rendered by them actually. Irrespective of the disparity in impact, the global response of the COVID-19 pandemic has largely been a one-size-fits-all, centered around centric approach, extensive lockdowns to ensure physical distancing while trying to maintain essential healthcare services to providing mainly emergency services, likewise COVID. Although we are spending a lot of money on healthcare system, but we are unprecedenting the infection resulted in additional health-related burden to the vulnerable groups such as mothers and children, the chronically ill, the elderly, and the people with special needs due to decrease in provision and utilization of usual healthcare. Considering the fact that the women and children are often the victims of poverty and ill health disparity, we have chosen to explore various aspects of maternal, neonatal, and child health care to understand the effect of COVID-19 response on such vulnerable and socially excluded groups, especially in low and middle income countries like India. So I would request the August panel to highlight the challenges faced by the beneficiaries and the healthcare system throughout the COVID-19 pandemic and in the current scenario as well. First in the panel, I would like to know from Dr. Kausar Amin, Assistant Director Schemes, Health Services Kashmir. Ma'am, as we know that during COVID-19 pandemic, emergency was declared and restrictions were put at the healthcare facilities actually to ensure the safety of the patients. So do you think these restrictions has impacted the provision of respectful maternity care at the health institutions?
Actually, in this part of the world, respectable mother care, we don't have that what is written in the books. We don't have that type of respectful mother care, the whole thing. But definitely there was an impact in the mother care because during labor especially. Like first and foremost, the lockdown happened. Because of the lockdown, we could not, there were restrictions. People could not visit the maternity centers, and when they did come, there was a restriction on the number of the companions they had with them, people with them. So that the emotional support which they get from their families, which their companions, that was missing. That was first and foremost. Secondly, because most of the institutions were closed down and we had just a handful of institutions in each district which had taken place pregnant females. So maybe it was for some of the patients it was an alien atmosphere. The hospital which they would visit regularly for the ANC or the doctors who cater to them were not there because of various reasons. Then alien atmosphere for them. Then after the delivery happened, after the delivery, there was a notion that we should not keep especially if they were COVID positive, there should be separation between the newborn and the mother. So we would take them away, that skin to skin care, which is where the breastfeeding, considering the breastfeeding, or no breastfeeding at all. That again had an impact. So this respectable mother care, which was supposed to be there, definitely that there was a different impact.
Thank you, ma'am, for sharing your experience actually. Ma'am, I would also like to know that were there any alternate provisions adopted by the healthcare system to cope up with these challenges? And according to you, what is the way forward actually?
Because of the closure of the main hospitals, most of our staff are doctors, are paramedics, and visited COVID, they have visited sampling and all those things. So what we did that most of the number of measures which was taken by the directorate was to all. So these in each district we took up the private nursing homes. It was an initiative which was taken up by the directorate with the help of the district administration. We took over the local nursing homes which were present in the district for maternity services. Because the hospitals were closed, there was COVID, most of them were dedicated as COVID hospitals. So for exclusively for maternity services, we took up the nursing homes and we rationalized the staff from the district. We kept our staff at the nursing homes and we did all the maternity services there. And in addition to that, we created a dedicated COVID hospital at Champura, which catered to especially the COVID positive mothers. And it was a very good, it was a successful program which was even highlighted by our Honorable Prime Minister in Man Ki Baat. That was another initiative which was taken by the directorate.
Thank you so much, ma'am, for sharing the innovative measures which were taken by the Director of Health Services. And I think That's how the new practices emerge in the healthcare system. Thank you so much, ma'am. Now, I would like to move to Dr. Rashid Farah, MS, DRDO Hospital. Sir, COVID-19 has increased the burden on healthcare system to many folds. That's very true. So, how did DRDO Hospital supplemented the efforts of health system to address the pandemic?
Thank you very much. As we know, that pandemic was the biggest test to humanity, and it was a huge challenge to the governments across the globe to address this kind of a challenge, which probably was unprecedented in history. And at this juncture, I would first, at the very onset, like to thank the NHM and would like to appreciate the NHM J&K for hosting this mega event that came immediately after a long COVID scare. Secondly, NHM deserves all praise and applaud for staying as a nucleus to gathering and dissemination of COVID information in the last 2 years and coordinating between different sectors in the midst of the pandemic for mobilizing resources and importantly for building huge oxygen capacities across the UT of J&K. I personally also have to thank MD NHM for supporting DRDO, especially by providing the budget for our 230 class 4 contractual staff and helping us with mobility support also. So this is my personal thanks to Mission Director NHM and his collective team. Now coming to the DRDO, I said that it was a collective challenge, and in this the government of India as well as the government of UT came out of this idea that they needed a supply, they created a chain of DRDO hospitals across the nation. And DRDO Srinagar and DRDO Jammu were such two hospitals which came up in a record 17 days. So this is for the first time that we can see that in a record 17 days, 510-bedded COVID hospital came up at Srinagar, which has 523 ward beds, 125 ICU beds, and 10 triage beds, and all beds were oxygen enabled. Then the infrastructure was so mammoth that if we have to speak about it, it is a huge infrastructure which consists of around 220 ventilators, high flow devices, around 30 to 40 high flow devices, bypass CPAP machines in innumerable number, and infusion pumps, the oxygen capacity through LMO. It was the first time that the liquid medical oxygen was used in this pandemic in this part of the state. And the LMO tank was about 556 kiloliters, which is almost 4.3 to 9 crore liters of gaseous oxygen. Besides the AC plants that were also generated, that were also put into use during this time. So this is at the 128 slice CT, the modern lab and radiology department, which supported the diagnostics of COVID during this period. So it was a huge beginning and something which we badly needed in the midst of the pandemic. And it importantly came up at the end of the second wave, and we were able to handle the third Omicron wave, where we received around 650 patients in just 26 days of the peak of the third wave, and out of them 73 patients were admitted into the ICU. Besides this, for the first time the government realized, I think most of our, I was listening to the previous session when one of our senior pediatricians from Anantnag talked about the manpower. And this is also unprecedented that this DRDO was provided with around 683 employees. Out of them, 143 were the nurses, 47 anesthesia technicians, 47 pharmacists. So it was a huge manpower that was put to our school. And this has happened for the first time. As a medical student, I had never seen such a number in any hospital. Then the doctors came from the Directorate of Health Services Kashmir. They supported us from their side, and we had 47 anesthetists on our rolls. Though the advertisement were put, we had only 7 or 8 anesthetists on the roll. They were running this ICU, and the amount of training and the skill that was gained from this pandemic. This time we don't have patients from last 2.5 months, but our staff is getting rotated into the associated hospitals and medical college. I am honored of getting calls from the medical superintendents of super specialty hospital and medical superintendent SMHS hospital that they want, especially the DRDO nurses in their ICUs and high dependency units, because of the skill that they attain pandemic in DRDO hospital. So this is regarding DRDO.
Thank you so much, sir, for sharing the achievements done by DRDO Hospital during COVID-19 pandemic. Sir, I would like to know that how do you perceive long COVID, and what do you think that it has implications of pregnancy or not?
I personally, DRDO hospital did not admit too much of pregnant ladies during the pandemic period, but we had an experience of admitting some pregnant ladies in the first or the second trimester whose illnesses were mild to moderate, and they were discharged. But we have a huge experience from the field, from the Director of Kashmir, from the medical college. The LD hospital put up mammoth work. The Chanakura hospital, led by Dr. Tajam Gadgam, did an exorbitant work which was reflected at various levels. And even the peripheral hospitals like District Hospital Pulwama, to the nursing homes in Pulwama, they did a wonderful job in handling these COVID patients in their respective areas. So what has come from the literature, though the lot of studies still going on the long COVID. The maternal health and long COVID is still being researched. There are some studies by the National Health Institute of the US and NHS of UK that the complete research work may take another 4 years to bring forth the long COVID and the maternity health in better perspective for the future. But the experience is that mostly it was a mild and moderate form of disease in the pregnant woman. There were certain complications. I think the gynecologists out here may be able to speak on that. Preterm labor, precipitated labor, or pregnancy loss. So these are certain things which have been recorded in the severe form of the COVID. But the challenge is how we have to ensure there's a risk that most of the time in pandemic we always thought of that whether we should go for pregnancy, should plan a child or not. So these were the things which most of our young couples faced during this pandemic. But the research says per se there is no risk because of the COVID. A family can be planned, and there are no deleterious effects of the COVID on the child bearing or the offspring that will be born. Vaccination has a huge role. The literature says that those pregnant ladies who before pregnancy, during pregnancy, or who had the booster dose had a smooth COVID period without any complications. So vaccination support is something which is very optimistic. Then there's the use of monoclonal antibodies, that is also pre-exposure treatment, which is also recommended for the pregnant ladies. That is also in the vast of the literature has been carried out. So per se there is no, we have not seen very severe disease of COVID in pregnancy. So certain complications, some of them landed in the ICU, but there were no major fatalities from the pregnancy side.
Thank you, sir. Thank you for sharing the insights of COVID-19 and its implications in pregnancy. So, my last question to you is that, what do you think that what are the safeguards to ensure safe motherhood in COVID-19 pandemic?
See, firstly, when we talk about the long COVID, you have to understand what this exactly long COVID means. So there are different entities which are incorporated into long COVID. Usually, the COVID resolves within the 4 weeks. So any illness or symptom that does not last, that does not resolve within these 4 weeks is something which we have to associate with the long COVID. So there is a symptomatic long COVID or the long COVID syndrome. So any illness which is beyond 4 weeks to 12 weeks or after 12 weeks is something which is being studied around. So we have a lot of things coming up like COVID lung, COVID heart, brain fogging and other things which are part of the COVID lungs, post-COVID syndromes. So these are being researched, and a lot of things are being spoken about these entities. So what I would suggest is that in our day-to-day clinics, in our OPDs, we will have to, especially those COVID patients who were admitted with us, who had complications or who had associated comorbidities, they should be followed up for a pretty long time. They should be followed for another 6, 7, 8 weeks, and their different COVID markers are to be monitored and reinvestigated and ordered so that we see how they are progressing in their
sir, for the valuable inputs on COVID-19 pregnancy and the safe mother. So before we move to Dr. Humara note, I would request the audience to keep on tweeting your thoughts and your questions with hashtag J&K MCH Conclave. So over to you, Dr. Humara, HOD, Gynae and Obs, GMC Banapura. Ma'am, we all know that GMC Banapura is catering the heavy population load in the whole country. In fact, I'm also witness when I was your institution last April. So, ma'am, what were the challenges faced by your institution during the deliveries of COVID-19 positive pregnant women and the newborn?
Thank you, Dr. Isha. First of all, as we all know, James Baramola caters to most of the North Kashmir, and we are dealing with both COVID as well as non-COVID. So it was a tough journey for us actually, because so we have to deal with COVID as well as non-COVID. So we cannot make each one of them suffer, either the COVID or the non-COVID. So because COVID was actually a challenge. It was a challenge for everybody around. It was something new. It was new to the entire planet. So it was something everybody was not prepared for, right? So at the same time, there was fear psychosis among everybody, among common people, among doctors, among paramedics. So that was a problem. So initially, there were hiccups, there were constraints pertaining to space, there were constraints pertaining to manpower, there were constraints pertaining to oxygen, so many other things. But then it was a challenge, and then it taught us so many things. And then we came out of it, we as winners, and we emerged as one of the best. As far as GMC Baramulla is concerned, since we have huge rush and we are dealing with all the specialities, be it medicine, be it surgery, everything. As far as the maternity services are concerned, first of all, space was a constraint, right? Because it's a new building, it's a new hospital, so everything was very new. And as far as space is concerned, isolation was the problem, because it was not something like a previous disorder where you could like keep patients together. So isolation was a problem. So as far as isolation is concerned, initially there were some constraints, but then with time the industry responded to action, and immediately we created some places where we kept patients who require oxygen or near isolation. After that, it was oxygen. That was initially a problem, but then right now we are self-sufficient. We have initially had 2 oxygen plants only, but then thanks to PM Care Fund, which gave us 1 oxygen plant, and right now we have 3 oxygen plants with a capacity of 3,650 liters per minute. Manpower. We still have manpower, the crunch is there, but somehow there was fair psychosis, and then doctors and various business staff was sitting over here and working over there, that despite so much of crunch and despite their families being in trouble, despite suffering from COVID, they came forward and they really, proved it that we have to serve humanity, and we have to serve our fellow people. Right now, initially training was a problem because doctors, paramedics, they were trained about how to deal with the situation. But now, thankfully, we have trained staff. They have been sent to higher centers where they have been trained, and they are well trained right now. We have one of the best trained staff right now available in our hospital. And at the same time, I'd like to thank NHM that they provided us with staff, ECRP package, where employees were provided as paramedics, doctors, who really helped us a lot, and we were able to come over this time. After that, ICU. Fortunately, what we can see that maternal severe disease was not a problem because we did not encounter any severe cases. But then ICU has been a problem because it was always at the back of your mind that if God forbid something happens, where these patients will land up, because our referral was very minimal. During this tenure, we did all the high-risk cases. Even though our center was not a COVID-dedicated center, but we had to be all the high-risk cases. I will share some details. In these 3 years, we did around 50 LSs. They were all high-risk cases. Previous 2, 3 scars, PH, anemia, diabetes, whatever the high-risk cases be. And we did around 30 to 40 normal deliveries, and they were all high-risk cases. And fetal-maternal outcome was, thankfully, it was everything was all right. So ICU was a problem, but now the problem has been overcome. And then a separate theatre, because segregation was a problem, because we could not let our normal patients suffer at the cost of COVID patients. So we not have a separate theatre facility, but with time we got a ground floor which is now recruited as a separate theatre where we can deal, God forbid, if any such circumstances arise. So we can be able to deal with those patients. And we have seen around 200 patients in this tenure. One laparotomy for ectopic pregnancy was done. So right now, there were the challenges in terms of space, manpower, oxygen, but right now we are self-sufficient and we have the capability to fight if, God forbid, the situation again arises. Thank you very much.
Thank you, ma'am. Thank you so much for highlighting those challenges faced by your institution. So, like you right now said that now you're self-sufficient and self-capable of facing those challenges again. So, I would also like to know that what steps were taken by the institution to overcome those issues and the challenges, and is there any kind of preparedness for such pandemic again?
Yes. Right now, first of all, oxygen. We have 3 oxygen plants with a capacity of 3,675 liters per minute. Second is the space. We have 50-bedded COVID dedicated hospital, which is fully equipped with all the necessary stuff there. And we have 8 high dependency beds also available. After that, we have a separate theatre that we have dedicated for COVID only, with a 10-bedded post-op ward and 2 theatres available in case emergency arises or we have COVID patients, we can deal with them. And yesterday, I'm thankful to Honorable LG sir, who yesterday inaugurated the maternal hybrid ICU. So we have now a maternal hybrid ICU with 10 beds, so that's the good thing. And then we have manpower that's trained to deal with such situations. Thank you very much.
Thank you so much, ma'am, for sharing your experiences, and I'm sure it must have been very challenging for you and your team to work under such circumstances, and we really appreciate that. So now over to Dr. Pankaj Samani, who is the Senior National Program Manager, Health System Strengthening at UND. Sir, in J&K, we remember Wednesday as the routine immunization. However, during the COVID-19, the healthcare providers lost the count of days, impacting the routine immunization very actively actually. So, we would like to know from you that what were the challenges faced during COVID-19 pandemic for the routine immunization services in children and pregnant women?
Thank you, Isha. First of all, good afternoon, everybody, and let me thank and congratulate Government of Jammu and Kashmir for organizing this first J&K MCH Conclave. And on behalf of UND Country Office, I would like to thank you for inviting us for this important discussion on MCH perspective during COVID-19. Going to the question what Isha you have put, yes. There were challenges as far as the routine immunization services are concerned, and the major reason what the earlier speakers have also said, the major reason was the lockdown. Yeah, and if we see the challenges, they were from both the perspective. I mean, from both the side, from the service delivery as well as from the demand side. During the lockdown, I mean, because of the lockdown, people were not able to access these services, so they were not able to go to the outreach sessions or even the facility-based session sites. So that was the major challenge for the people to access these services. And there was a lot of, and in fact, again, from the demand side again, there was a lot of migration. I mean, there was a panic in the starting of the pandemic, and people were migrating. There was in-migration, out-migration, and the settlements were they've just left their settlements. And because of that, they didn't know where to go for the vaccination services. They were mainly worried about the COVID-19 disease rather than any other immunization services or facilities. And if I talk about, and then a major factor which was deterring the people to go and take the services was the fear of catching COVID. I mean, if they go and visit these facilities or even the healthcare facilities, they thought that they may catch COVID while getting the RI services. So they were reluctant to go and get even the normal healthcare from the healthcare facilities. So that was from the demand side. And if I talk about the service delivery point of view, yes, when the COVID-19 started, I mean when the pandemic started, nothing much was known about the disease progression or how it will go. So the entire staff the entire healthcare staff, they were all busy with the COVID-19 duties. Mainly our vaccinators, the ANMs, and the frontline workers, they were all busy with the COVID-19 duties. So yes, because of that, the RI services were hampered, and not only just that, but even the frontline workers and the healthcare workers, they were also affected by COVID. So because of that, also they were not able to provide the services to the beneficiaries. And there was another point regarding the supply chain. During the pandemic, again, the supply chain was also disrupted a bit, and the supply of vaccines to the last miles, I mean to the session sites, because they are really carried by the AVDs or even the transportation of vaccines. Somehow, I mean, somewhat it was disrupted, although not much, but yes, that was also a factor initially. So these are all the factors of lower coverage of vaccination services. I mean, if I talk about these challenges, they were mainly in 2020 and 21, because as is evident from the NFHS 5 data also, the coverage has actually improved. The immunization coverage has actually improved. But if you see the coverage data from 19 to 20, yes, there is a dip in the immunization coverage for the entire country, and yes, even for the maybe for the states also, which has come out from the surveys conducted by WHO and many other partner agencies, the monitoring which they do monthly. So yes, there was a dip in the coverage from 19 to 20 during the COVID pandemic.
Thank you, sir. Thank you so much for highlighting the barriers that affected the coverage of routine immunization during COVID-19. Sir, how does the government address those issues, and what were the steps taken by the government to ensure an effective rollout of routine immunization as well as COVID-19 vaccination?
So if I talk about continuing these services for MCH, rather not MCH but RMCHA, which also includes national services. So there were frequent guidelines and guidelines which were given by the ministry. I remember the first was given